welcome to the panel on Reimagine, Reboot, Retool, Healthcare Post-COVID. I want to welcome our panelists and also the audience to what I hope will be a lively discussion on what the pandemic has revealed about our healthcare system, both in terms of new, exciting, emerging technologies that have been accelerated, and also by what clearly needs to be repaired in terms of our healthcare system. My name is Reed Abelson. I'm a reporter with the New York Times, and I cover healthcare with a particular emphasis on the business of healthcare. During the pandemic, I've been watching carefully and closely about how our healthcare system is adapting by embracing new technologies, as well as what it's doing and revealing about the inequities in our healthcare system. I'd like to say we're going to cover a few topics today. We're going to look at the technological, structural, and social divides that the pandemic has exposed, and how those divides have slowed efforts to control the spread of the virus, as well as even now, the rollout of the vaccine. We'll be talking about how the COVID-19 pandemic has accelerated adoption of certain technologies and what they are. And if indeed America's healthcare system needs to be rebuilt, what are the potential steps for rebuilding it? With that, we'll ask each of the panelists to introduce him or herself, starting with Rich Isaacs.
Hello, it's a pleasure to be with you all today, and thank you. My name is Dr. Rich Isaacs. I'm a head and neck oncologic surgeon, and I'm the CEO and the executive director of the Permanente Medical Group here in Northern California, and also the president and CEO of the Mid-Atlantic Permanente Medical Group and the co-CEO of the Permanente Federation. Together, we support 23,000 Permanente physicians nationwide with 80,000 employees, and we take care of 12.7 million Americans from Hawaii through to the Mid-Atlantic states.
Okay, thank you. Jennifer?
Hello, and great to join you today. I'm honored to be part of this panel and to join Dr. Isaacs and Lisa Sunanen. I am Dr. Jennifer Merez, cardiologist and Northwell's Chief Diversity and Inclusion Officer, as well as the Senior Vice President for the Center for Equity of Care at Northwell. Northwell is in New York State, predominantly in Long Island. We are New York State's largest health system, 75,000 employees, 23 hospitals, and 1,000 ambulatory sites. We have a school of medicine, a school of nursing, as well as a research institute, and we take care of 8 million New Yorkers from Long Island, New York City, and Northern Westchester. And thrilled to be here today.
And Lisa?
Hi, everybody. Lisa Sunan here. I'm the lead of the digital technology practice at Manat, Phelps & Phillips, which is a national law firm, consulting firm, and also a venture fund, which I lead. I'm also on faculty at the UC Berkeley School of Business.
Okay, great. Well, thank you all for being here. I think this will be really fascinating to discuss what's going on. And let's first talk about the pandemic and how it's exposed systemic weak points in our healthcare infrastructure. And I'm really curious, in your respective roles, what has been the most striking example you've witnessed during the crisis? What are the important lessons you think we as a country have learned from COVID-19? And Rich, I'd like to start with you.
Thank you so much. Was the CEO of the medical groups on both coasts and co-CEO of the Permanente Federation. One of the obvious weak points was a striking lack of coordination at the national, state, and the local levels across this country. For example, early on, because of a lack of coordination with personal protective equipment, PPE, health systems like ours were competing with every other health system across the state and the nation to purchase the much needed PPE for our people to keep them safe and to also provide care. So there were significant problems across the country. From a technology standpoint, we learned that both the private and the public health sectors' technology and communications infrastructure were lacking and they need to be updated. Turnaround time for tests, for example, was a significant problem. In the beginning, it was taking up to 10 days and sometimes longer for the results to come in. And when you're trying to control a pandemic, those results are pretty much, irrelevant. So last spring, Kaiser Permanente internalized much of our testing. We built a new testing center and within 8 weeks to give us the added capacity to process up to 20,000 tests per day in the state of California. And this enabled us to significantly reduce the turnaround time for results, which was critical in supporting the initial response to the virus. And then the pandemic further highlighted disparities in health. There were, gaps in access to care that were further exacerbated by the global pandemic that we experienced in this country. So Kaiser Permanente, in partnership with the state of California, has made a $63 million investment to create a network of community health teams that will enhance state and county-led contact tracing efforts and connect patients with the appropriate supportive services. The program is based on a contact tracing pilot that our infectious disease physicians here in San Jose developed last spring to reach patients more quickly and to achieve better outcomes.
It's really interesting. And Jennifer, what about you? What's your perspective?
So I think New York was the epicenter, and we got hit really hard about a year ago. And to add on to what Rich said, what was glaring to us was definitely the disparities. You couple that with the fact that there was no playbook for this, and we were sort of building the plane as we were flying it, as my colleagues like to say. We figured quickly, as we were looking at our hospitals filling up, that we had to create our own playbook. And what was important for us, we had to partner with our community. So we discovered that, even though we serve 8 million community members, and that if you use English or preferred language as a surrogate for disparities, we serve 50% of our population speak a preferred language other than English. We recognized that our partnership with our communities needed to be strengthened. And so we quickly did a few things in terms of testing, in terms of education about COVID, because knowledge is power, as well as providing PPE. We first partnered with New York State to get definitely in testing stations established, similar to what they did at Kaiser Permanente. But we also formed a coalition with our faith-based leaders and community members, and began testing at over 100 faith-based leaders got together, and we began testing in churches. Additionally, we established a health equity task force with our community-based organizations to not only do testing, but education and now vaccine rollout. What was also great for us and we quickly discovered this, that our communities or underserved communities were getting hit hard and furious. The trust wasn't there, but the trust was built when we established this coalition. And what we were able to do was to test rapidly, identify those who needed to be hospitalized. And because we had 23 hospitals and we were writing the playbook, we were able to develop something we call load balancing, move people to get access to all the clinical trials and great care. Additionally, we began enrolling many of our community members in community trials and started collecting the data and published our data in JAMA. So building trust and the community partnership and making investments in our communities was definitely one solution to move forward.
That's interesting. Lisa, I'm curious what you found.
I was, but in that I don't come from a provider organization, but I work with many and with also other aspects of the healthcare system, including those who manufacture drugs and devices and the like. I was really struck by the damage to the supply chain and how we as a nation are so reliant on overseas products to build our necessary medical products and services and to deliver those here, and how we hadn't prepared for that in any way, for the disruption of the supply chain on a massive global basis. Further, I think one of the biggest disruptions or kind of unpredictable things that I saw that I think dramatically affected the direction of the pandemic and the negative direction of the pandemic was the disconnect between people or among people around the importance of science and education around science, and how that played out, how many people just didn't believe, didn't want to believe, couldn't understand, and thus behaved in ways that really hampered the effort to slow the virus down and to address the impact. And I think, I wish I could say that there had been some great solution brought to the table on either of those fronts. I haven't seen much yet. I'm hopeful that, some of the Buy American initiatives and educational initiatives that we are hoping to see in this new administration will address some of those issues. But I think those were things that nobody really expected.
That's really interesting. I guess in terms of sort of talking about specific structural gaps, particularly in the use of technology and also to address the social divides exposed during the pandemic, I'm curious what kind of structural gaps you thought contributed to the inability to control the virus's spread and to distribute right now the vaccine. And why don't we start with Jennifer?
So I think, to build on what Lisa said, I think COVID pandemic was a sobering reality that our care was fragmented, right? That we have fragmented healthcare. One arm is not talking to the other. And I think of the Leonard Cohen song, "There's a crack in everything, and that's how the light gets in." And this was clearly that example. And I think we see here fragmented care. We also see here a focus on acute care, that our health system was built for acute care. We worry about getting you in and out of the hospital and not recognizing that 80% of health outcomes depends on everything outside of the healthcare encounter. And I think that this was clearly evident here, where you needed education, the social determinants of health that impact ability to seek care, to feel better, to follow healthcare instructions, clearly apparent. And it really issues a call for us all to truly join that public, private partnership with healthcare organization and other agencies in society to truly look at healthcare holistically and universally. And I think, as I joke with my colleagues, in 2011, Surgeon General Regina Benjamin gave us America's plan for better health and wellness. And I think it's time we sort of take it out of the archives, because there is a clear-cut plan to follow. And we, over the past 10 years, because we have formalized our approach to diversity, inclusion, and health equity, have adopted, our sort of healthcare delivery model from that plan. And I think that helped us build a foundation to truly start testing quickly, partner with our communities, do education, and now, truly enhance our vaccine rollout.
Lisa, what do you think? I mean, obviously, you seem, I think, rightfully rather pessimistic. What do you think are some of the structural gaps that we could address here?
Well, we have to start by addressing the gap of of how we deliver healthcare in facilities, for one thing. And we've been talking for years about, as Jennifer points out, social determinants of health. We've been talking for years about moving care towards the home, and yet business models in the healthcare system really don't align around doing those things, and they need to be realigned if we're going to do those things effectively. We also have to be thinking about what we value in terms of what's funded, in research and development. We have not valued things like funding vaccines or funding anti-infectives. Those are not the hot IPOs, right? But they are now. So I think, thinking long-term instead of short-term about how we fund and support companies, whether they're public or private, in terms of, public stock market or privately held, we really need to be thinking about where our R&D dollars go and our support of organizations that can respond to crises like this. I mean, I think it's so much farther than the health system, so far beyond the health system, that we need to address these issues. And we have the knowledge, and we certainly even have the science or the capability. It's just, what do we have the will?
That's interesting. Rich, what about your perspective? I'm curious what you think.
So I think as a physician, what we saw, and I think we see this in every pandemic during history, just the lack of clarity of information. And I already mentioned how we have an uncoordinated approach between the national and the state and the county levels. And I think that that created a lot of confusion early on. So that was one gap. We also saw, as Jennifer mentioned, continued social divides in which older adults, people of color, and low-income families who congregate in small dwellings is where we saw very rapid spread of virus early on. Frontline workers who had the inability to take time off from work because of the importance of the cash flow into their families, and then also working in inadequate workplaces. In Central California, for example, we have migrant farm workers who were moving from farm to farm for harvest and living in small quarters during the nighttime, and we saw rampant spread of infection through there. So to help address some of these barriers, Kaiser Permanente has been providing members with a home suppression kit that contains a 14-day supply of items like hand sanitizers, masks that prevent the spread of disease within the homes. So we also awarded an $8 million grant to dozens of grassroots organizations across the state to focus on racial inequity and access to care by mitigating some of the social determinants of care in coronavirus pandemic.
So obviously out of necessity, the pandemic accelerated certain kinds of new technologies. And I'm curious from your vantage point, which ones really stand out as ones that you think will have the most significant and lasting impact on healthcare? And Lisa, I'd like to start with you.
Sure. I think we've all been hanging around, or many of us in the healthcare tech world, for a long time, and doing a lot more talking than we have been acting. And finally, I think the pandemic pushed us over the line into the world of virtual care and ways that are, thank God for that, because otherwise we would really have had even more trouble than we already did. But I think telemedicine and the like is, too simple of an answer. I think the other technologies that it's facilitated and other things related to the pandemic have facilitated are things like home diagnostics and care at hospital at home type of care, which we've long talked about, but now just finally have started to really do, and it's working. It's going well. I think we've started to see much more use of thoughtful data analytics, so identifying and predicting who might get sick and how you might intervene before it's too late. Again, we've been talking about these prescriptive and predictive analytics things forever and really haven't put them much into practice, but now we are starting to see some of that for disease surveillance and intervention. So I think there are many actually technologies that have been sitting on the sidelines a little too much over the years, well funded but not well used, and now we're starting to see some of that catch up. So it's I'm glad to see that.
Rich, I'm interested in your perspective from a practical standpoint. I mean, what did you see emerge as sort of a really useful and what you think will be long-lasting technology?
Yeah, so I agree with what Lisa is saying. Almost immediately and overnight, our providers transformed the way we do care delivery. We didn't have the ability to bring patients into our medical offices, so we turned to telehealth. And the medical group, for example, here in Northern California was doing 80% of all patient contact via video visits. And what we found is there's tremendous value for our patients and also for our physicians. And in 2020, the Permanente Medical Group here in Northern California did 3.7 million televisits from March until the end of the year. And contrast that with where we were the year before, we had done 100,000 across our population. So I believe that the pandemic really forced transformational change. And now our job is to try to harvest that to see where the value add is in use of this technology moving forward. It's really about creating convenient access, meeting the patients where they are using the technology, and providing really a 24/7 house call that can also direct patients to the right access point within the healthcare delivery system, which I think will have huge benefits moving forward. The emergency departments in the nation now are overcrowded. That's where people are going to get their care. if we can leverage the technology like we've seen during the pandemic, we may be able to provide more consultative work upstream and dictate care delivery in the future.
And Jennifer, what do you think?
So to add to what Rich and Lisa said, I think, telehealth for Northwell increased significantly, probably not to the tune of millions, but significantly hundreds of thousands. I think for us, what we also recognize is how we communicate with our patients was definitely sort of a very tenuous situation. Because with COVID, you get hospitalized, and we took care of probably over 50,000 COVID patients. We screened over 100,000 people in our communities. But what we recognized, because you had to be in isolation, or community members, because our health equity task force members told us we needed to amplify the way that patients and their families communicated. And so we increased or tablets or iPads at the bedside so that people were able to communicate with their loved ones. Everyone, almost 95% of people have some sort of smartphone. So we increased our technology so that patients and their family members could really speak to the medical staff. And in some heartbreaking cases, it was the way of saying goodbye. So we have recognized that, smartphones, iPads, truly important. We also notice, coming back to the language piece and preferred language, that we had to amplify or video remote interpretation, because one of our hubs is in Queens, where there are 172 different languages. And so having built a foundation with our language access and understanding where our patients were coming from, their preferred language based on site, we were able to quickly amplify our video remote interpretation to increase communication. But I think for us, what was really heartbreaking was initially when we started, not being able to have loved ones say goodbye or to talk to their family members, and increasing, tablets and iPads made that possible.
That's clearly been, one of the lasting impressions I think people have who've lost a loved one in this. So I'm curious, stepping back, how healthcare, you folks think healthcare has changed since the pandemic started, and what changes you think need to occur. And I'm thinking about sort of what kinds of policy changes, investments, or other kinds of steps need to take place or need to happen to facilitate the adoption of new technologies to make sure that they're lasting and permanent. And also, obviously, very importantly, how to address the inequities in healthcare access and delivery. And Rich, if you don't mind, I'll start with you.
Thank you for that. I think the shift to telehealth and virtual care has been the biggest shift. And the shift to telehealth usage was enabled by some significant changes in regulations and also billing. So previously, Medicare telehealth coverage was very limited. And now Medicare allows office visits via telehealth, where services are provided by physicians and other ancillary providers in the comfort of patients' homes or even in the emergency department. So the HHS Inspector General waived Medicare cost-sharing requirements for COVID-19 treatment delivered via telehealth from a doctor's office, a hospital, or an emergency department. In addition, Medicare offered payment parity and waived geographic restrictions. Medicaid expanded coverage, including coverage for audio-only care. All of these opened up and really accelerated the use of this technology to provide care. And CMS added 144 services that could be furnished via telehealth and relaxed interstate licensure, waiving Medicaid and Medicare requirements that physicians be licensed in the state where they provide the services. These are the type of regulations that I'm hoping we can harvest and bring forward into the future so that we can accelerate the use of technology integration into care delivery and improve the quality of care to all Americans.
Jennifer, what are your thoughts about this?
I think Rich is spot on. We definitely need national, state level changes. And I think, to definitely expand the healthcare delivery model, moving back to what, was highlighted in that document, the National Prevention Strategy. And along those lines, I think importantly, on a much more local, granular level, Northwell Health has been instrumental in leading the way in fostering the partnership with community-based organizations, faith-based leaders, and local community leaders who understand the needs, especially for underserved communities. So we have focused our attention on our underserved communities. Our Health Equity Task Force, made up of over 100 members from the community, state legislators, have been instrumental in sort of guiding and expanding our healthcare delivery strategy. And it has been so effective that when we look at the results in terms of race, ethnicity, preferred language for survival from COVID, decrease in hospitalization, we have noticed that our communities of color, underserved communities, have actually done, we don't see a glaring disparity as we see in other parts of the nation. And I say, so the key message here, adding to what Rich said, is partnership. That public, private partnership is definitely important. And truly recognizing that healthcare delivery has to go beyond the acute setting to include the determinants of health. And that's something we have been working on at Northwell, to partner with housing facilities, with schools, to increase and access to care and meet people exactly where they're at. And I think another important piece is education. Your health is your most important asset, and really pushing to get health and wellness as a core curriculum in the schools from an early age is something that we have been working at Northwell Health.
Okay. Lisa, what are your thoughts?
Well, I think, I agree with a lot of the policy statements that Rich made. I think we also are going to need really enforceable, effective policy on interoperability of data if we're really going to be precise in our delivery of healthcare and make decisions more quickly. We don't have that now, and we need it. We're going to need regulation and policy around supply chain and having critical mass of key supplies available, stockpiled in the country where we need them. We're going to need to be a little more assertive, I think, about, emergency policy. What does that really mean? Does it mean that people can opt out for, whatever reason they choose, or just because of real emergency? I think, we didn't have great compliance with the few strictures that were provided, and now we're going to need to do a better job figuring out how to be enforceable or how to enforce some of these things. God forbid they should happen again. And I do think we're going to need to be more thoughtful about what we tolerate, from the healthcare system. We did some pretty magical things during this pandemic. We were able to speed up drug delivery, drug discovery and creation in a fundamentally interesting and positive way, which we need to figure out how to keep doing that in a safe way, but in a real way. We have empowered organizations to do care in communities, including the retail pharmacies, but also cultural, religious organizations. We need to empower them to keep doing that and get paid for the effort and the work that they do. And I think we also need to think about how we treat caregivers and what that impact on the economy is if those caregivers were forced away from their jobs to take care of family members, which they were. In December, all of the jobs lost in the country were women. 100% of the job loss was women. In case you didn't hear that right, 100% of the job loss in the economy was women in December. This is because women were forced out of the economy taking care of family members during this pandemic, and that is not acceptable for that to happen. So we need to figure out how to prevent that and either compensate caregivers for the work that they do or find an alternative way to take care of people's families.
So, you all, alas, as I have been around for a while, and we all know there have been sort of innumerable attempts to revamp healthcare. All you have to do is think about Haven, right? The Amazon, JP Morgan Chase, and Berkshire Hathaway attempt by employers to suddenly, control healthcare. That I guess, finally officially called it quits earlier this year. And again, we've been talking for decades about how to overhaul the healthcare system, how to make fundamental changes to improve quality, improve access and affordability. And I'm curious whether, you think the pandemic has been a catalyst for any significant attempts to really reimagine and revisualize the healthcare system. And Jennifer, I'll start with you.
So I think tough question, but I am an optimist. The glass is always half open. And I am sort of encouraged by the realization that, the health of a nation depends on the health of every single person. So I think that this will be a catalyst. And now we have sort of we have leadership that recognizes the urgent need to truly sort of unbundle the old-fashioned of health, the old traditional approach of healthcare delivery, and truly build this partnership focusing on 4 areas, I would say. Definitely coalitions with communities so that communities are educated. You have community workers, you have the technology to hotspot, to identify what their diseases are, so that community members become partners in ensuring the health of their fellow community members. We should have preventive services, and we need to sort of dust off and revamp our preventive and public health sort of algorithms to definitely have healthy and safe communities. And then I think we come to the fact, of empowered people, that the education about health and wellness, especially with the epidemic of chronic diseases, and COVID showed us that we have to be active participants, and we need education, and especially in our underserved communities, and educating in multiple languages, and the health literacy piece, truly important. And fourthly, a true focus and intentional approach on the elimination of health disparities. So I feel that, as I always say, the roadmap is there, we need to use it. And I think, at Northwell, we have been sort of following that plan. It's been a climbing Mount Everest. But I think when you look at our statistics and we look at the fact that our communities of color were not as badly affected by COVID as some other communities, I think we give credit to implementing strategies of looking at the social determinants of health and truly following some of the guidelines listed. But I am optimistic. So I am hoping that if we were to meet 10 years from now, or when the next pandemic occurs, that we have a better roadmap.
Okay. Lisa, I'm curious if you share that optimism.
I'd like to, but I'm not sure if I do. I think in some ways, yes, there's definitely more interest in doing, definitely more interest, I think, and more willingness to take care of underserved populations. Hopefully, the money will follow that interest, because I think in the end, whether we like it or not, the healthcare system is largely coin operated, and we need to drive incentives, financial incentives to drive behavior. So some combination of regulation and financial incentives is usually what makes things change. I worry because I think it's human nature to revert to the mean. Everybody's trying to, get back to normal, whatever that means. And if we get back to normal in the healthcare system, we're going back to, it doesn't work so great for a lot of people. And so we have to be willing to light ourselves on fire a little bit in order to move ahead. And that is not easy for people to do. So I'm hopeful. I'm not sure if I'm optimistic. I'm a little bit in the middle.
Okay. Rich, I'm curious on that spectrum where you are.
So I'm coming in with Jennifer on an optimistic side,
Okay.
but with cautious optimism. Thank you, Lisa, for that. The reason why I'm optimistic is because the changes that we've been making at Kaiser Permanente over the last 2 decades are now much more visible for people to see. And I think it's very good that the new administration is committed to moving quickly to address some of the changes that need to be made. We need a technology infrastructure that allows systems to communicate with each other. And as you look through this most recent pandemic, I think it's a case study in what needs to change in order to provide care. So you talk about prevention. some of the very simple things, wear a mask, wash your hands, avoid contact. We could have been way ahead of this as a nation if we just had a coordinated communication plan that started at the federal to the state to the county levels. I do believe that it is, as has been said, it's a public-private partnership that we need to work together to improve the health of the entire community. We've identified obvious social determinants of health, and how do we bridge those gaps? Because it's going to benefit the entire community if we can do that. So I'm optimistic. I'm very excited. I think that this pandemic has really accelerated technology integration. We're going to clearly need a lot of help from the federal government and state governments with regulatory change to help facilitate the necessary transformation to take place. But I'm optimistic.
That's certainly, that's,
you know, and I think, you know, if we could somehow remind people that we're all interconnected and that, you know, we are in this together, if we can keep the humanism piece alive and going, we could collectively move the needle on a better healthcare system. But I think Lisa is correct that people, you know, the pandemic is fatiguing and people are just wanting to go back to some normalcy, you know, and I think we need a multi-pronged approach.
So anyone else have any last thoughts on this before we wrap this up? Anyone want to go first?
I'm going to go back to America's Plan for Better Health and Wellness. Let us get it out there. And I'm appealing to the current Surgeon General, his second time around, to definitely build a coalition of all the different Surgeon Generals. We need all the expert help we can get. And let's write about what we have learned and let's have an implementation plan, multi-pronged approach with multiple agencies, multiple private sectors. Let's move forward.
And let's educate children when they're young about the importance of health and healthcare and community. So when they are older and can make choices, they make good ones.
Yeah.
And I agree with Jennifer. I had an opportunity to spend some time with Vivek Murthy last year before the pandemic. I think one of the most important things that we need moving forward is a focus more on integrated care and coverage, where the incentives are aligned to promote health, to prevent disease, and get away from the fragmented fee-for-service world that, as Lisa said, is very coin operated. If we have organizations that are focused on population health and the prevention of heart attacks and strokes and the prevention of complex disease, that's the future. And I feel that we are in a really good position right now coming out of COVID-19 to build those blocks for the American healthcare system.
Okay. Well, wow. Thank you all. I mean, I think this has been really fascinating and, you know, mostly optimistic, sometimes not so much. But I want to thank you, you know, for all participating and thanks to everyone for tuning in to the panel to learn, you know, and guess what healthcare may look like post-COVID. And I hope we get to post-COVID as quickly as possible. But thanks very much.
Thanks, Reed.
Thank you.
Thank you.